Welcome back, everyone. Today, we're diving into the GPS of the human body. Before you can perform a complex surgery or even a basic physical exam, you have to know how to navigate. And in anatomy, that navigation starts with standard body movements. Dr. Sarah, are you ready to map this out?
Absolutely, Dr. Khan. For students, this is the foundational vocabulary. If you can't describe a movement accurately, you can't document a physical exam. For the boards, you must always assume the anatomical position as your starting point, standing erect, palms facing forward, toes pointing ahead. If you forget that the palms face forward, your descriptions of medial and lateral for the forearm will be completely backwards.
Exactly. It's like the home screen on your phone. Everything starts there. Let's jump into the big ones, flexion and extension. I like to think of flexion as closing the angle of a joint, like folding a pocket knife. Why does this matter clinically? Well, if a patient can't flex their elbow after a fall, we're looking at specific muscle tears or bony blocks.
To be precise for the exams, flexion and extension occur in the sagittal plane. Flexion usually involves an anterior movement, except for the knee. That's a classic board trap. Knee flexion is a posterior movement. Extension, on the other hand, is increasing that joint angle, essentially straightening the limb.
Right, the knee is the rebel of the group. Now, what about moving away from the body? Abduction and adduction. I tell my students, abduction is like being abducted by aliens. You are being taken away from the midline. Adduction is adding back to the midline.
That's a great mnemonic. On a high-yield note, remember that for the fingers and toes, the midline isn't the center of the body. It's the middle finger or the second toe. Spreading your fingers is abduction. Bringing them together is adduction. This comes up often when testing the ulnar and median nerves.
Speaking of nerves, I was talking to the doctor of choice at our clinic yesterday about a patient with a suspected rotator cuff tear. We had to test circumduction. Now, students often confuse this with rotation. Dr. Sarah, how do you keep those straight for the students?
It's a common point of confusion. Rotation is a bone turning around its own long axis. Think of a screwdriver or someone shaking their head no. Circumduction is much more complex. It's a combination of flexion, extension, abduction, and adduction. It traces a cone in space. The shoulder and hip are the prime examples because they are ball and socket joints.
I love that cone analogy. It really helps visualize the movement. Now, let's talk about the forearm, pronation and supination. This is where most students trip up during the practicals.
The high-yield tip here is supination allows you to hold a bowl of soup. Your palm faces upward or anteriorly. In pronation, the radius actually crosses over the ulna and the palm faces posteriorly. This isn't just rotation, it's a unique specialized movement of the forearm.
And why does this matter clinically? Think about a nursemaid's elbow in a toddler. They stop supinating because the radial head has subluxated. If you don't understand the mechanics of supination, you can't perform the reduction to fix it.
Moving down to the feet, we have another set of specialized terms, dorsiflexion and plantar flexion. Dorsiflexion is bringing the toes up toward the shin. Plantar flexion is pointing the toes down, like a ballerina. These are basically the foot's versions of extension and flexion, but we use specific terms to avoid confusion.
And don't forget inversion and eversion. Inversion is tilting the sole of the foot inward toward the midline. Eversion is tilting it out. Why does this matter? Most ankle sprains are inversion injuries because the lateral ligaments are more commonly stretched when the foot rolls inward.
Great clinical tie-in. We should also touch on the jaw and shoulders, protraction and retraction. Protraction is moving a part forward, like jutting your chin out. Retraction is pulling it back. On the boards, they might ask about the muscles that retract the scapula, like the rhomboids, when you're pulling your shoulders back to stand up straight.
It's all about the pull and the direction. We've covered a lot of ground, but the key takeaway is that these aren't just fancy Latin words. They are the universal language of medicine. If I tell a surgeon a patient has limited internal rotation of the hip, they know exactly what I mean without us even being in the same room.
Exactly. For your exams, focus on the planes, sagittal for flexion extension, coronal for abduction adduction, and remember the exceptions like the knee and the thumb. If you master the terminology now, the muscle actions later will make so much more sense.
Well said. To wrap up, start with the anatomical position. Use abduction for taking away, adduction for adding, and remember that circumduction is the cone while rotation is the screwdriver. Master these and you're well on your way to mastering the physical exam.
Thanks for the great discussion, Dr. Khan. We'll see everyone in the next session where we get into the bones themselves.